Ron Richards is a lucky man. He was right near a level 1 trauma centre when the car hit him. After sustaining multiple leg fractures, a smashed pelvis and a crushed chest, Ron's heart stopped beating in the emergency department, but the medical team brought him back to life. In theatre, he receives massive blood transfusion and life-saving surgery.
The good thing that everything went very well, so we managed to control his bleeding from the chest and the pelvis.
But days later, while recovering in intensive care, Ron's organs begin to fail, one by one. First, his liver starts to deteriorate. Then his lungs fail, followed by his kidneys, dramatically lowering Ron's chances of survival. It's an all too familiar story in trauma units across the world. A patient survives the initial injuries and then dies from multiple organ failure.
Everyone happy to go the rest of the way on 3? Yeah. 1, 2.
Why it can happen to severely injured patients like Ron has so far been a mystery. Now an Australian team is beginning to unravel the cause, and it offers a strange glimpse into the ancient life within us all. Ron was walking along this grassy verge when he was hit from behind at 60 kilometres an hour. That's a force greater than the human body is evolved to withstand.
The highest energy injury 100 years ago was falling off from a horse. Fracture here on the pubic rami.
These days we not only travel at great speeds, but medicine is also moving forward at a cracking pace. It means patients like Ron can now survive the unsurvivable.
We are faster getting the patient into hospital, or resuscitation strategies improved. We use more blood and blood components, or surgical techniques may be faster. During the last 30 years, trauma care improved tremendously.
Ironically, this has led to the emergence of a deadly secondary condition, multiple organ failure. The strange thing about multiple organ failure is it usually sets in 3 to 5 days after severe trauma, without any sign of infection and without any injury to the organs involved.
So by that stage they're looking pretty swollen and not like themselves at all. Their blood pressure will start to go down and their heart rate will go up. We also see it in the way their blood tests start to deteriorate.
As the body becomes more inflamed, lungs, liver, heart and kidneys begin to shut down.
Everything's going wrong at the same time, really. It's very serious, and that unfortunately they're much more likely to die.
It's the #1 killer of trauma patients who survive serious injury. Doctors have been trying for decades to figure out what triggers multiple organ failure, but it wasn't until a few years ago that a team in Boston came up with the vital clue. In the blood of severely injured patients, they found high levels of free-floating DNA. But it wasn't DNA from the human chromosome. This DNA belonged to something that can trace its origins to a much older time, around 1.5 billion years older. What they found was very high levels of mitochondrial DNA. Mitochondria are the powerhouses of eukaryotic cells, which make up some of the most diverse creatures on Earth today, from plant life to fish to mammals.
One of the benefits of having mitochondria is that you can produce energy cheaply. And so if a cell has high energy demands, you need a lot of mitochondria.
What's peculiar about mitochondria is they still retain their own primitive DNA.
Mitochondria have their own genome. It's much smaller than the nuclear genome and it's circular. And that's very similar to what you find in bacteria.
It's thought that 1.5 billion years ago, a bacterium was engulfed by a single-celled organism, creating the eukaryotic cell. But the ancient DNA stays safely locked away behind a double membrane and never enters our bloodstream. At least, that's how it's supposed to work.
The tissue injury due to trauma causing cell disruption, cell death, and all the contents of the cells leaks out.
Cell death on a massive scale explains the high levels of mitochondrial DNA found free-floating in the blood immediately after severe trauma. But it didn't explain why multiple organ failure sets in 5 days later.
To me, it was still a mystery.
The team in Newcastle decided to take the experiment a step further.
We monitored patients up to 10-15 days after injury.
To their surprise, after an initial decrease, levels of mitochondrial DNA in the blood began to suddenly and rapidly increase, without any further injury to the body.
So this increase here doesn't make any sense to me. We first thought that this is something wrong or error in our measurement.
Oh, no, it's huge.
Levels peaked exactly when multiple organ failure usually sets in.
In day 3, day 5, it was very, very high, higher than at the time of the injury.
The only way mitochondrial DNA could increase in this way was if it was somehow escaping from living cells. But how this would be happening in trauma patients was an unknown. Professor Barlog went back to the latest research to look for clues.
So he found in infectious disease literature, white blood cells, when they encounter bacteria, they do an extraordinary thing.
When confronted with bacteria, white blood cells, or neutrophil leukocytes, behave like predatory spiders. They spit out a web or net to trap the invaders, then hit them with a deadly oxidative blast.
Mitochondrial DNA is very similar looking like bacterial DNA. And if bacteria is triggering leukocytes, we thought that maybe the mitochondrial DNA does the same.
What's more, the nets themselves had been shown to be full of DNA. If this happened to be mitochondrial DNA, this would trigger even more white blood cells to attack, causing a vicious cycle of inflammation. To test the theory, the team from Newcastle separated the white blood cells of severely injured patients and used coloured stains to identify the DNA. Under the microscope, this is what they found. The blue stain shows up living white blood cells. The green stain shows up any DNA escaping from those cells. And it was clear these cells were in attack mode, literally bursting their DNA across the screen. So is that green burst a net in action?
All these green stained areas are nets.
A further red stain shows how much of the DNA in the nets themselves is mitochondrial.
And for surprise, this is
All
what
of
we
it?
saw.
It must have been amazing to see.
It was an amazing discovery to see.
The stains confirmed that mitochondrial DNA is the culprit behind the deadly inflammatory cascade in multiple organ failure.
It's very fascinating that the inflammation after trauma is driven by our own body.
The attacking white blood cells migrate from the bloodstream into major organs. Here, as they spit out more nets and continue their toxic oxidative blasts, they cause mass tissue damage, leading to total organ shutdown.
I'm studying multiple organ failure in the last 20 years. Nobody knew that cells can do this in trauma without infection. Just amazing. This is what we thought going to happen.
It's a fascinating example of just how far we've come down the evolutionary path. Some parts of our cells originate so far back in time that they appear alien to our most vital processes. These nets are moving into the spotlight in many other areas of medical research, including heart disease, stroke and cancer. Monitoring mitochondrial DNA levels in patients like Ron can help time surgery better to avoid the extreme inflammation that leads to multiple organ failure. Doctors can also rapidly distinguish between infection and trauma-driven inflammation. As for Ron, his organ function returned to normal, and he's begun the long road to rehabilitation.
How are you feeling? All right? Doing that all right?
Yeah, I just feel so happy to be here and talking to you. Yeah, very nearly wasn't.
Okay, very well done.
He still considers himself a lucky man.
That's great. Good day. Today lecture titled Multiple Organ Dysfunction Syndrome. By the end of this lecture, you have to be able to know the definition of multiple organ dysfunction syndrome, know the clinical manifestations of multiple organ dysfunction syndrome and what are the risk factors, the pathophysiological mechanism of multiple organ dysfunction syndrome, what is the nursing assessment parameters to confirm the diagnosis of multiple organ dysfunction syndrome, and how to implement the nursing care plan based on a priority for patients with multiple organ dysfunction syndrome, communicate effectively with patients, family and healthcare provider, and document your data and adhere to the code of ethics. As you know, dysfunction means inadequate function of the organ. So multiple organ dysfunction syndrome is considered when a progressive dysfunction of two or more organ system occur. So we can consider the multiple organ dysfunction syndrome or MODS as a condition of uncontrolled inflammatory response to severe illness, severe injury, and organ dysfunction. So as we mentioned in the previous lecture of systemic inflammatory response syndrome, in which we, based on the pathophysiological changes, we consider the modes as a consequence of SEERS, which affect the patient's perfusion and oxygenation in different conditions, such as shock or severe illness. We can classify the multiple organ dysfunction syndrome into two main types: primary modes and secondary modes. In the primary one, there is a direct insult or injury affected the organ and resulting in organ dysfunction, such as in case of blunt chest trauma, which may predispose or leads to adult respiratory distress syndrome. While secondary modes or multiple organ dysfunction syndrome is a situation in which organ dysfunction occurs as a consequence to another insult or as a consequence of another condition occurred to the patients, such as host response impairment, which is mainly characterized by generalized activation of the inflammatory response in organ remote from initial insult, such as wound infection may predispose to sepsis or acute pancreatitis. In general, you have to know that secondary multiple organ dysfunction syndrome can be developed within 7 to 10 days post-exposure to the primary insult. There are many triggering factors or causes predisposed to multiple organ dysfunction syndrome, such as sepsis and severe sepsis, major surgery, or with post-operative major surgical complications, burned patients, shock state, multiple or massive blood transfusion, infections, aspirations, pancreatitis, patients with acute renal failure, patients with adult respiratory distress syndrome, and finally, necrotic tissue development. Regarding the pathophysiology of multiple organ dysfunction syndrome, 4 major criteria mainly manifested the patients with multiple organ dysfunction syndrome and occur in the following consequence. First, inflammation, then altered in coagulation, then impairment in the fibrinolytic activity, and finally endothelial dysfunction. So starting with the first response, which is inflammation, there is a site of insult due to injury or hypoperfusion or whatever the cause. This insult activates the inflammatory response locally, then predisposed to the release of various cytokines from macrophages, such as tumor necrotic factor alpha and interleukin 1. These we are calling them as pro-inflammatory mediators. Then this predisposed to activation of neutrophils and endothelium release of vasodilatory substance, such as nitric oxide, histamine, and bradykinin. We call them as anti-inflammatory mediators. So both pro-inflammatory mediators and anti-inflammatory mediators predispose to the inflammatory response and resulting in additional capillary leak from the blood vessel and resulting in extravasation of the plasma and altered in the coagulation factors. Altered in coagulation factors usually very linked with the inflammatory process. As we mentioned before, in the systematic inflammatory response syndrome, it predisposed to the release of cytokines from macrophages, TNF alpha and IL-1, and lead to coagulation and platelets activation for the intrinsic and extrinsic coagulation cascade in the critically ill patient's body. This coagulation occurs at the level of microcirculation of each organ and then predispose the organ to dysfunctional and even death. Then the third response will develop over releasing of these inflammatory mediators leads to dysfunction of the coagulation pathway and affect the fibrinolysis activity, which predispose the patients to higher bleeding tendency, such as in a patient with severe sepsis, fibrinolytic activity may impair due to increased production of plasminogen activator inhibitor and thrombin activated fibrinolysis inhibitor. All these factors will result in inability to dissolve the clot. The blood flow will be reduced at microcirculation level and finally organ dysfunction and death will occur. That's why, as a consequence of inflammation, altered coagulation, and the impairment of fibrinolysis, endothelial dysfunction will occur. And as you know, the function of the endothelium to control the vasomotor tone and traffic the nutrients all over the body and maintain blood fluidity. Whereas the production of these inflammatory mediators as well as the toxins from the organism of infection or from the source of infection will result in maldistribution or abnormal distribution of the circulation and increase the microvascular permeability, which with altered in the patient's coagulation, it affected the patients and resulting in microthrombi formation as well as edema. Adding to this problem, the patient's the endothelial dysfunction will result in impairment of the vasomotor tone, as we mentioned before in systemic inflammatory response syndrome lecture, which is resulting in vascular relaxation, and finally end with hypotension. Hypotension with impairment of circulatory blood flow, which finally result in organ dysfunction. As you remember, we mentioned this concept map for the development of systematic inflammatory response syndrome. How can it worsen and predispose to multiple organ dysfunction syndrome? Moreover, this concept map shows how the primary modes with more deterioration and systemic inflammatory response syndrome development can be worsened and developed secondary modes. Now we finished the first part of multiple organ dysfunction syndrome lecture. We discussed already what is the meaning of multiple organ dysfunction syndrome, the triggering factors, the causes, the pathophysiological mechanism, and the concept map for the development of multiple organ dysfunction syndrome. And now go to the second part, which will include, after finishing the pathophysiology of modes, how the patients can develop either primary modes or secondary modes, دلوقتي هنمسك بقى system starting with cardiovascular system. الكارديوفاسكولار dysfunction ممكن تبقى result من الهايبوبرفيوجن، ودي في حالة البرايمري مودز، أو any hypoperfusion reason for the patients like shock conditions or post-traumatic or whatever result in secondary cardiovascular impairment. The mechanism of developing cardiovascular dysfunction: first, inflammatory mediators, vasoactive mediators will cause vasodilatation, as we mentioned before. الفازودايلاتيشن هتعمل لي hypotension، plus كمان في additional impairment of vasopressin. الفازوبرسين ده هيعمل لي more persistent vasodilatation, adding to decrease myocardial contractility and increase in microvascular permeability. All these factors predispose to regional hypoperfusion, as in case of sepsis, which interfere with the distribution of systemic blood flow، زي ما احنا قلنا قبل كده في shifting أو maldistribution of the circulation from non-vital organ to vital organ. The condition can be more worsened in state of acidosis and hypoxemia. Regarding the gastrointestinal tract, remember, in case of sepsis or injury, bacteria and microorganisms can be translocated from the GIT system and secrete and release its toxins. Its toxins can be reached to the circulation, systemic circulation, and extending to the inflammatory process. Then septic shock can cause paralytic ileus and can lead to delay in the institutional of feeding. That's why you have, as a critical care nurse, you have to start enteral feeding as early as possible within the first 24 hours from ICU admission. Regarding the respiratory system, you have to remember that the bacterial translocation can result in moods. So here, this is a type of secondary moods, while pneumonia and adult respiratory distress syndrome can cause primary moods towards the pulmonary dysfunction. So you have to know that pulmonary dysfunction can be directly predisposed to primary moods, or pulmonary dysfunction can be a complication or a consequence of another cause and predisposed to secondary moods. In such case, what happened in your patients? Endothelial injury in the pulmonary circulation lead to disturbance in the capillary blood flow. This disturbance in the capillary blood flow may result in interstitial and alveolar edema. in addition to increase the neutrophils in the pulmonary circulations, may initiate and increase the alveolar capillary membrane permeability and worsen the patient's condition. This leads to ventilation-perfusion mismatching, in addition to pulmonary edema and adult respiratory distress syndrome are considered as a common manifestation for the patients with multiple organ dysfunction syndrome. Finally, arterial hypoxemia will be developed. In relation to the hepatic dysfunction, it can be cause to modes, primary modes, or result or effect from hemodynamic alteration in the liver, either direct or indirect insult in the hepatocytes, and then leads to secondary modes. While if there is a direct injury in the liver or direct affection of the liver circulation, actually it will affect the liver function. Liver is the detox organ which is responsible for discard the toxins from the body. So if there is an impairment in liver circulation or there is a liver failure, it will cause primary modes. You have to remember that hepatic dysfunction always associated with impairment of coagulopathy and hypoalbuminemia. Both of them can lead to organ edema. Moreover, liver dysfunction leads to widespread of the bacteria into the systemic circulation. Also, you have to remember that liver failure or liver dysfunction associated with higher liver enzymes, higher serum bilirubin, and altered in coagulation function. Also, as you know, liver is the detox organ, so the liver with dysfunction will impair or fail to excrete the toxins from the patient's body, especially ammonia. Ammonia accumulation will result in encephalopathy. Regarding the renal dysfunction, it can be cause to primary modes, or as in case of activation of endothelium with reduction of the release of vasoconstrictors and vasodilators, or it can be a result from systematic hypoperfusion and result in secondary modes. In case of acute kidney injury, there is a decrease in the intravascular volume due to systemic hypotension. Also, direct renal vasoconstriction to overcome this state leads to release also of the cytokines and the activation of neutrophils by endotoxins and other peptides. Finally, all these toxins will contribute to the development of acute renal injury. Regarding the central nervous system, affection of the central nervous system in case of sepsis is very common and can lead to encephalopathy and peripheral neuropathy in case of secondary modes. Also, the pathogenesis is purely defined but likely related to systemic hypotension or cerebral hypoperfusion. In relation to coagulopathy or alteration of the coagulation factors in the patients, there is a mild elevation of thrombin or activated partial thromboplastin time with a moderate reduction in platelet count, which is thrombocytopenia, and finally will contribute to DIC, disseminated intravascular coagulopathy, which is a serious and severe and acute state, and it's considered as a life-threatening health problem for critically ill patients. Also, deficiency in coagulation system protein, including protein C and antithrombin C, and the tissue factor inhibitors also can cause coagulopathy impairment. To summarize what we mentioned before, how far the moods affect all body system, you will find in this table each organ system, pulmonary system, cardiovascular system, and renal system. And in the second column, you will find the clinical manifestation common among the patients with systematic inflammatory response syndrome. And in the third column, you will find the common clinical manifestation according to each body system and common in patients who developed multiple organ dysfunction syndrome. You have to remember all these clinical manifestations and all these signs and symptoms. In this slide also, the rest of other body system, hematological system, hepatic system, and the neurologic system. Also here, you will find the gastrointestinal tract system and the metabolic system, and finally the immune system. Welcome back again, my dear students. Now, after we finished already the first part and second part of multiple organ dysfunction syndrome lecture, now we're gonna to present the final part and third part of the lecture, which will include the most common line of management and preventive strategies for multiple organ dysfunction syndrome, which will include preventive strategies as well as supportive strategies. First, for the preventive measures, which mainly aim to maintaining the tissue oxygenation and preventing iatrogenic complications and maintaining gut integrity and function, and prevent the proper management of pressure ulcer, proper wound care and wound management, prevention and control of infection, especially healthcare provider associated infection, and finally vigorous and strict organ support. Regarding to the measures to maintain tissue oxygenation, as you see here, all these interventions will emphasize on how improve the tissue oxygenation for patients who developed mood, including using of incentive spirometry, chest physiotherapy, nebulization, suctioning, and use of care bundles to prevent DVT, aspiration bundles, oxygen therapy, and mechanical ventilation demand. Here we will find the measures to improve the oxygen transport and oxygen delivery. Both of them aim to improve the tissue perfusion, which will be performed to the patients by improving the fluid volume status, provide intravenous fluid resuscitation either by colloid or crystalloid, use of vasopressor therapy, avoidance of Valsalva maneuvers or any strains, evacuation of the tension pneumothorax if present, relief of cardiac tamponade if present, and improve myocardial contractility through inotropic therapy, and management to prevent and improve myocardial ischemia. Also, proper management of patients who develop acidosis, either respiratory or metabolic, proper glycemic control, and try to maintain oxygen level below 150 milligram per deciliter. Blood and the blood transfusion product will increase the oxygen transport capacity by increasing the hemoglobin level to increase the oxygen capacity. Recombinant human activated protein C. Activate protein C has may be helpful intervention for the patients to improve the patient's perfusion, which because it has anti-thrombotic effect, anti-inflammatory effect, and fibrinolytic properties. In relation to the measures to decrease the oxygen demand, the critical care nurse should control any conditions that lead to increase oxygen demand. You have to control all these conditions by maintaining a normal thermic condition, because fever and hyperthermia increase the oxygen demand. Avoid the underfeeding or overfeeding. Prevent convulsion and chills, sedation and muscle relaxation, and the proper management of patients' pain, stress, and anxiety. Regarding complication prevention, you have the critical care nurse should implement strategies to prevent stress ulcer, such as initiating proton pump inhibitors medications or histamine 2 receptors antagonists, and also implement the protective lung ventilation strategies for the patients with adult respiratory distress syndrome, which include tidal volume of 6 milli per kg of patient's body weight and plateau pressure less than 30 centimeter of water. In relation to the measures to maintaining the gut integrity, as we mentioned before, the development of GIT complications is very common among the patients with MOD, and the involvement of gastrointestinal tract system is very common due to translocation of the bacteria into systemic circulations. So you have to assess your patient's readiness for early enteral nutrition, and should be established within the first 24 hours from ICU admission. Provide sufficient caloric requirement, which ranged from 25 up to 35 kilocalorie per kilogram per day, and maintain protein supply from 1.8 up to 3 gram per kilogram of body weight, of patient's body weight per day, and provide adequate fluid supply, as we mentioned before, in a bundle of sepsis in patients with SIRS. Provide glucose containing fluid should be used carefully. Maintain serum electrolyte level within normal. So you have to monitor serum electrolyte daily, and provide vitamins and mineral supplementation as required. In relation to prevention and management of pressure ulcer, apply the skin bundle for prevention of pressure ulcer and the early detection of pressure ulcer. Also, early assessment of the patient's risk to develop pressure ulcer, such as using a Braden scale. In relation to wound repair and management, you have to assess a traumatic wound carefully with surgical repair if required. Implement strict adherence with aseptic technique during the wound dressing, and report any abnormal finding to the physician, and drain any abscess if present. In relation to prevention and control of infection, especially from healthcare provider, you have to conduct the protocol to highly adhere to infection control in the ICU, as according to the hospital policy. Try to minimize the number of invasive devices and invasive lines as possible. Conduct proper isolation if required. Review the protocols required for infection, and adhere to the infection control guideline, and encourage breathing and coughing exercise and early ambulation as early as possible. And don't forget, go to the basics, adhere to proper hand hygiene, protective barriers, and all this stuff. In relation to the prevention for infection, again, we have you previously study the VAP bundle to manage the patient's ventilator-associated pneumonia, apply central venous catheter insertion care bundle, avoid the use of any unnecessary bundles, and administer culture-specific antibiotics. As you know, there is an abuse for the use of antibiotics in many ICU, that you have to don't start any antibiotics before doing the culture antibiotic. In relation to the vigorous organ transport, it must be implemented to support the dysfunctioning organ to prevent multiple organ involvement. Regarding to one of the major strategy to prevent multiple organ dysfunction syndrome is early detection of patient's risk to develop multiple organ dysfunction syndrome. One of the most common assessment scoring system used to assess the patient's risk for modes, namely sequential or sepsis-related organ failure assessment scoring system. SOFA is very common scoring system, and it is very easy one. It used to assess the risk of 6 organs in the patient's body. Each organ or each system scored from 1 to nearly normal or borderline, and 4 to extremely abnormal. So the scoring of SOFA will range from 0 for risk-free patients and up to 24 for extremely risk patients to develop pressure. As you see here, a 6-body system will be assessed by SOFA to exclude the risk of each organ to develop organ failure. The first system will be the respiratory system, will be assessed by measuring the oxygenation index, which will be measured by divide the partial pressure of arterial oxygen tension divided by FiO, fraction of inspired oxygen. For example, if your patients have PaO2 of 85 millimeter mercury and FiO2 of 50%, you will divide 85 divided by 0.5. Then go to assess the hematological system by platelet count. As you know, normal platelet count equal to 150,000 up to 400,000. Then hepatic system will be assessed through measuring the patient's serum bilirubin level. Cardiovascular system will be assessed by monitoring the patient's mean arterial blood pressure, which can be calculated by the formula of measuring systolic pressure plus 2 diastolic pressure divided by 3. And then to the central nervous system, which will be assessed through assessing the patient's level of consciousness using Glasgow Coma Scale. And the final system will be assessed is the kidney or the renal system by measuring the serum creatinine. On the here also on the table on the right side, you will find the SOFA scoring references with corresponding mortality rates for each scoring reference. As you see here, this is the SOFA description table. In the first column, you will find the 6 systems will be assessed, and in the first row, you will find the different scoring starting from 1 up to 4, and in each row, you will find the corresponding description of each score. The usual protocol is to assess the critically ill patients upon admission, upon ICU admission, and then reassess your patients on a periodic interval to evaluate the patient's progress or the patient's risk to develop multiple organ dysfunction syndrome. In relation to the supportive therapy for patients who had multiple organ dysfunction syndrome, remember that the major key elements important for each patient's developed mood, including proper fluid resuscitation, hemodynamic monitoring and hemodynamic support, maintenance of tissue oxygenation, providing nutritional support as well as metabolic support, and consider that your patients at a higher catabolic state, try to control the patient's pain and improve your patient's comfort and support the patients for individual organ dysfunction. And remember, supportive therapy is very key element to improve the patients, but remember it's a very life-threatening condition. At the end, here are examples of most common nursing diagnoses among the patients who developed multiple organ dysfunction syndrome, and we have to remember very well. To summarize, you have to remember and take a home message that multiple organ dysfunction syndrome is a very serious and life-threatening problem to critically ill patients, and you as a critical care nurse, you have to work hardly on the preventive measures, how to prevent the development of multiple organ dysfunction syndrome among the patients at risk, and how to prevent the development of complications that may develop secondary modes. And finally, remember, prevention much better rather than cure. And thank you.